Well, what are manufacturers doing now? Supposing you can't get this drug approved, at least not classically. Are the manufacturers stepping in to help with cost control for some patients?
They will. There are manufacturer patient assistance programs.
Okay.
Now, assistance programs are typically for indigent patients, those who can't afford the therapy.
That's what you hear on television, right? If you can't afford this drug,
right,
that we may be able to help you with that.
Exactly.
Okay.
So, so there is help for some patients who are indigent. There's also help for patients, for commercially insured patients with commercial copay cards.
Yep.
And there are some foundations that are supporting.
Where you struggle is with your Medicare patients, because they usually don't qualify for patient assistance because they have a government-funded insurance. Occasionally you can get some help, but they have to be, what, 300–400% below the federal poverty level. It can be hard, and that's who a lot of these patients are. They're 65 years and older, and they have Medicare, and we can't get their help. It's costing them $300 a month on a fixed income. So.
Well, I struggle with the copay cards for commercial patients, especially in a self-funded insurance program for an employer group, because it's taking the patient decision out of the equation. We talked about, well, now copays are a little bit higher, so patients are making better decisions about whether they need it. If you take that totally out, then it drives prescribing, because then the patient's equivocal about whether they're going to use it, because it's not going to cost them.
And they like it because it goes towards their deductible.
We can love all day. We can talk all day about our love-hate relationship with these types of programs. But if appropriate, and again, it gets back. We keep saying appropriate. If the drug's appropriate for a patient, whatever we can do to make the drug more affordable, to help with compliance, everything else, we're all for. But it's when these coupons are used to circumvent the benefit and drive inappropriate utilization, maybe before a statin or any number of other reasons, then that's where we have problems.
Oh, if you're saying use our coupon, it's affordable, that'll be your copay, and then you don't have to be on a statin and you don't have to do this other stuff, that's not an appropriate use of the coupon, is what you're saying.
When they're used to circumvent tiering and steps and other things, then we don't like them. But if they're used in patients who are on the drug and should be on the drug, then fantastic.
All right. Correct. So let's just round this all up, and everybody can jump in on this. Are we as a society making the correct cost versus clinical benefit right now, today? I mean, you all sort of alluded to this, that if you give these drugs and they work up to their promise, people will live longer and the cost of society will be lower, maybe. But the drugs themselves cost a lot. And if you start paying for these drugs, your fourth quarter doesn't get made. In fact, it gets trashed. So are we right now where we should be with this?
I don't think so. I don't think we're there. Again, I look to Europe. I think they're ahead of us a little bit. But obviously prices in Europe of drugs are considerably less money. So I would love to work with societies, SPs, providers, everything else, and get to some kind of consensus where there was a quality just of life here or value threshold on how we were covering medications. Then we would have some kind of leverage with how these drugs are priced. So right now, unfortunately, there are too many silos that exist. So there are misincentives driving towards rebates. There are misincentives doing all kinds of different things. So I don't think we're doing this appropriately. But again, the key is we're practicing population-based medicine. And so we have to figure out the right channels for individualizing that to the right patient.
Well, you're practicing population-based medicine, and some people are practicing individual patient-based medicine. And these are the two conflicts, right? This is where the push and the pull is. What do you think?
Well, I think, and I keep coming back to this, but I think it's an important point in that I do think these drugs are good and they're going to be good for people, but I also think that we're using drugs too often and taking some responsibility away from the patients for doing what they should do as well. So how do we incorporate patient responsibility into the cost of all this? Stopping smoking, eating appropriately.
Right. So here we are.
Yes.
Here we are back where we started.
Back where I started.
and back with these really hard choices. Mm-hmm. I mean, it's as hard as paying for this is, and as hard as getting approval is, that's harder. Getting buy-in from patients to change their diet, change their weight, stop smoking, that doesn't happen.
It doesn't, but I think we have to factor patient personal responsibility into this somehow. And I don't know how to do it. I don't have the answer to that.
Well, he could do it. He could say, unless you lose 50 pounds, you can't have this drug.
Sure.
Oh,
I don't know.
He could do that.
Incorporate it
Some
into prior authorizations.
Some employer groups are actually offering incentives for patients to to enroll in weight loss programs, to enroll in smoking cessation programs and those types of things. So there are ways to do it, I think, with incentivizing the patient to do that.
But
I think you have to incorporate that in when you're talking about drugs that cost this much. You have to, whether it's employer-based or whatever it is.
you talk about long-term data, you don't have enough long-term, I got long-term data
Mm-hmm.
on weight loss, doesn't work. Smoking cessation, reasonably ineffective,
Mm-hmm.
right? Diet change, get off the hamburgers, doesn't work.
Mm-hmm.
I mean, and unless you change human nature, change the human race, doesn't work.
Mm-hmm.
So is that a non-starter?
No.
You're such
You're
an
right.
optimist.
It's hard, I know, but I feel like we have to incorporate the patient responsibility into it, and I don't know how that works, but I don't think we can not acknowledge that piece of the puzzle.
Yep, and the mechanisms right now are deductibles, co-insurance, things I mentioned, and those are not long-term solutions.
Are there long-term cost benefits looking forward to all of this here in terms of using these drugs versus not using these drugs?
I think so. I want to go back though and
Go ahead.
address some of the things that are being done. So there are some self-insured employers, some that offer programs that are designed around the patient's and the employee's everyday life. So for instance, if I work at a grocery store and my discount at the grocery store depends on my BMI, my weight, whether or not I smoke, and it ranges maybe from, say, 20% to 30%, there's incentive every single day for me to make sure that I'm getting the maximum amount of discount on everything. So there are some employers who are doing some pretty novel things.
All right. What
To
do
get
we
patients
need,
engaged.
What do we need to know right now that we don't know to make this discussion easier? Is it that we just need more research and the way these drugs are being used, or do we need to know something else? What do you
I think from our perspective, where we sit, we would like clear guidelines. So, Jeff mentioned his guidelines. That's beautiful that we're relying on diagnosis from a cardiologist, and it's based on the cardiologist and the patient and those reported information from LDL and then the patient history. Where we have struggle is it's all across the board, the barrier to access from a criteria perspective. So standardized criteria would certainly help.
From a clinical practice, I would completely agree. If the criteria were uniform, it would be much easier.
And I think that would help too, because we have 80% initial denials, and Jeff said he's getting prescriptions in or requests in where there's no statin use. So maybe it's a prescriber education through guidelines.
Yeah. I agree with guidelines. Better data, obviously cost containment. You can use, there's all kinds of examples. Hep C is a perfect example. That was a huge concern with states and payers, just given the prevalence, again, and the cost of these medications. And the criteria initially was very restrictive. As we got a third entry, due to competition, prices came down, criteria opened up. We're not going to get a third entry here. So, if you address the cost issues, then we've said this a couple times today, then the cost effectiveness equation changes, and we have more funds to treat more patients.
Okay. Look, it's been a tremendous discussion, and there's still more to talk about. But what I think that we really have to do at this point is give you each a moment by yourselves to leave us with one important point that you think that we may not have covered or you really want to cover again. So each of you gets one last shot at the audience. And Cheryl, why don't you start?
Wonderful. So I think that not only with this class of drugs, but with all classes of drugs that we're dealing with, we're seeing patients out of pocket higher. We have 47% of self-insured employers have these high out-of-pocket deductible plans, and patients are opting in because of economic purposes. No one expects to become the patient who gets written the PCSK9. So understanding that patients will end up in situations where the $300 out of pocket just cannot happen. I think, coming together as the overall society, making sure that those who need the drug therapy get the therapy.
Bryan?
I think that after all we've talked about the studies, still it's very clear that the primary treatment of these patients are with high intensity, maximally tolerated statins. And I think with the growing data we have with not only the LDL reduction, with the benefit in patients with ASCVD and the right patient, that these drugs are an alternative, clinically speaking, an alternative add-on to a maximally tolerated statin therapy.
Jeff?
Well, I could probably refer to similar things, reduction in cost, better data. If I had to pick one thing, I think I would just focus on the better collaboration between the different stakeholders so that we have a better understanding of who the appropriate patient is. We can reduce barriers to access, and we can prescribe these more appropriately.
And that leaves you, Jennifer. The last word.
Yes, well, I'll echo Brian's thoughts mostly in that making sure that we're using these in the appropriate patients also. Jeff's thought, always the appropriate patient. Adjunctive therapy, not forgetting that these are just a piece of the puzzle, that we need to start with statins and lifestyle modifications and all of those important things. Again, not as the sole treatment, but just as a piece of the puzzle.
Well, I want to thank all of you. This has been a great discussion. Everybody got beaten up. That means, that means it's good. I want to thank you, too, for watching. I'll see you next time. I'm Dr. Peter Salgo.